this knuckle moved out.
Oh, yeah,
It
look
used to
at
be
that.
recessed like that one.
Yeah, look
Like,
at that.
it used to be recessed like this one.
You gotta get an x-ray. We got urgent care. Probably be cheaper.
St. People's Children's right by 25th Street.
Yeah, it's an x-ray, hand x-ray. I'll tell you where it's broke or just.
It doesn't hurt though. It's just
Don't feel right.
feels, yeah. But I'm having back for aggression as well.
They are heavy.
They touch the wheels, yeah. And that airplane is not supposed to be touching your butt off the wall.
So your kids making noise yesterday.
Did you hear that? They were upstairs.
We all have family, that's good.
They do some like
It's when they get older and then they're on the phone and they start screaming.
in a lot of ways, the cars
That was my daughter. She is.
don't have passengers, so they fly close to the
She's
airport,
wild.
fly fast. It's a lot of the airline stuff that flies
You get a
slow,
copy of that? Jermaine Green.
These guys,
Hmm?
they make
Jermaine Green
money
printed something up. I don't know if you got a copy.
they're not
What is
passenger
it?
comfort.
Just said referring something to the
It's quick, they
solicitor.
kind of
He
get the
said
point
there
from A to B.
some canned
Should be
responses.
less distance.
Caught wind of the Packer.
Hmm?
He caught wind of the Packer. Case when NBC was here and she was pushing us for a statement. He said, instead of just referring everything to the solicitor, he wrote down some stuff.
Yeah, they're only coming out at 17, not 78, 77. Fuel economy and spacing. And whatnot.
It's classified. Sounds really technical.
Yeah, I ran into him on the way,
And get them directed. All right, 5:30. 5:30.
It's time for that meeting there, Mr. Vaughn, you're the boss. Put that in your canteen close.
Yes, this is the Human Services Committee meeting for March.
See that? She's not ready for it.
All this peer pressure. I care less what he says, but.
That'll make a lot.
Okay. Human Services Committee meeting for March 16th, 2017. First item on the agenda is our courtesy of the floor. Moving along. Second item on the agenda is the update on Gracedale Nursing Home. Thanks.
Okay, if don't mind if I get started. First thing, of course, is census. We have, even though you do see a slight increase in the census here, we actually have been over, I'd say, in the mid-650s since February 15th. And we've even reached our budget of 660. Today we are at 655, but we have 9 admissions coming in. So we're definitely heading in the right direction. You will definitely see a higher average for March than you did for February or for January. And with regards to bed hold days, there's less bed hold days, well, because there's less people leaving the facility. But let me just go into the whole big changes. Pretty much everything is the same. I will tell you that we have an increase in the number of our Medicare A stays than we did before, which is very good because usually the trend seems to be going downward when you're having issues with your census. But in our case, we're not. We're having more Med A residents. If you take a look at the specialty ADC from 22.7, oh no, I'm sorry, I'm reading the wrong one. From the Medicare ADC from 32.7 to 36.5 on the 4th line down. Okay, referral time is down, but we're increasing the number of referrals that we're actually turning into admissions from 34% to 42%. Any other questions before I move on to finance? No? Okay. Our cost per resident day has increased, but that's because when you take in more admissions, you spend more, for that, so it is a little bit higher, and it'll continue to grow as our census grows. Okay. With regards to our case mix index, we have gone from 0.8 to 0.83. It seems like a small number, but it's actually a pretty good number that's heading in the right direction. Our goal is 1.0 on our case mix index so that we can get greater reimbursement for our Medicare A stays. So we're looking at hopefully by May to have it at 1.0.
What do we need to change?
Or what do they do to reach that?
Well, it's basically capturing all of the skilled need that we provide in our care plan meetings and in our MDS assessments, the minimum data set assessment that you do the tool. You have to capture it within a certain date. So that means that everybody has to work harder to get it within that time. So this way Medicare can recognize it, and that's what bumps up your score, your CMI. So it's a collaborative effort that has to continually occur, and the documentation and everything has to continually be there so you can raise that CMI or case mix index.
Did you, Louis, notice any maybe decrease in the case mix index on account of the implementation of the electronic records, kind of the learning curve to get on all the documentation into the records?
Yeah, I mean, because of the adjustment into that, there can be some, but it's minimal. You're not going to get a huge amount. You're able to really stay on track with it because of the minimum data set's been around for many years. So it's just a matter of getting the information in there, but we've been reporting the MDSs to the state for years, so that doesn't change. It's getting that, capturing that date, and that can be part of the electronic medical record. Any other questions before I move on? No? Okay. Our Medicare reimbursement, we don't have the numbers yet for February. We don't usually get them until the end of February, but I'll report those in March for February. Nursing hours PPD, we are maintaining 3.2 on our nursing hours, so we're steady with that. And now we're just going into overtime for nursing. We have seen a slight increase in all of the nursing hours and overtime, not except for RNs. RNs went down a little bit. Our LPNs went from 818 to 1,017, and the CN hours went from 2,451 to 3,200. With regards to the LPN, we did have the increase in census, so we do have some increase in overtime while we try to fill the positions that we have, and we do have a massive, it's a massive event with human resources to try to get in more nurses into our facility and fill those positions. Yes, a recruiting event. Yeah, that's what I meant to say. It's a recruiting event. And with regards to the CNAs, I don't know if you remember that I had talked about that resident who we were going to try to get into a New Jersey home with Huntington's Korea. Well, it wasn't the home. The home accepted her, but New Jersey Medicaid, because she's on Pennsylvania Medicaid, switching over to New Jersey, decided to reject her because they felt that she did not have enough nursing home qualifications to be considered for New Jersey Medicaid, meaning that she didn't have 3 or more activities of daily living that a nursing home requires, or her cognitive level was not decreased enough for them. So since they're holding on to the purse string, so to speak, if they turn it down, then even if the facility accepts it, they're not going to accept it for New Jersey Medicaid. But what they did say is to keep watching her, because as soon as she starts to deteriorate, then you can reapply, and they can probably accept her at that point. But she's not at that point yet to be nursing home certifiable for New Jersey Medicaid. So she's still ours, which means we still have a 24/7 on her. And we do try to reduce, but in her situation, you're never going to, because her behaviors, if anything, get worse as her condition progresses.
If they are more equipped to handle her, is there a way that she could still go over there, and even if we picked up the tab, would it still be a benefit to us? Is that a possibility? Or,
well, we actually were looking to do that initially, is to pick up the tab for the first month, which we would have gotten reimbursed by Medicaid, once she was New Jersey Medicaid eligible, but we would be picking up the tab every month until she deteriorates, and then they finally consider her. And then she's over there, so we're not really knowing how much she's deteriorating, where we could watch her here and get her there faster than if she's already there. They might say, well, she's private paying, let's just keep it going.
Right.
You know what I mean? So I just think, it's not in the best interest for us to keep her, because it is costing us more for the one-to-one than it would be not having her. But I just think we'll know when we can reapply and get her in there. So we will be staying on top of that. Don't worry. Okay. All right. Any other questions about overtime? Yes.
Please.
Sure.
I just want to try and sort through this. So the RN hours basically were flat in February. The LPN hours went up 24% in overtime, and the CNA hours went up almost 31%, over 30%.
Right.
In a month that was 10% shorter, and we only had essentially 1% more people. Mm-hmm. So I'm still kind of lost on how that equation works itself out.
With regard to that individual who
Yeah, I know, but you're talking about one person. So one person you're saying one person drove 1,000 hours of overtime?
Well, we have actually over 5 people still on one-to-one. She's the only one who's a full 24/7. And during the month of January, she was in Sacred Heart Behavioral Center for most of January.
Okay.
So that's why you didn't see it until she came back in February, and then it hit pretty hard because of the 24/7.
Okay.
Yep.
So if you have one individual, that, even though 24/7, 28 days, that's 670 hours, I could see, I guess, where that could be a bulk of it.
Yeah. I will tell you, though, that the other people have been reduced. One is actually going to come off, and that was our lady who, had
Right.
the issue. She's practically going to be weaned off completely.
Okay.
Oh, I'm sorry. Do you have a question?
Yeah, so kind of going where Glenn was going, I guess we don't necessarily, so let me just understand this. If we have, say, like an LPN, right, and she has her responsibilities, so she can't be just delegated to a one-to-one. She has to actually be paid overtime during that shift to sit as a one-to-one?
Well, it would be a CNA in that situation.
A
not an
CNA, right,
LPN,
sorry.
yeah. With the CNA, it depends on the situation. What we try to do is we pay them within the time and not to utilize the overtime. But if you have call-offs and you have to replace those call-offs with people to take care of the people who need care, and then the one-to-one also has to be, you try to juggle, and you want to get in the least amount of overtime possible, but sometimes you can't.
It
depending
almost
on-
sounds to me like it might be even cheaper to create a position for just one-to-ones. Just a thought, just throwing it out there. I mean, if you always have one-to-ones.
So many nurses' aid positions that it's, you know what I mean, you have several hundred of them. So the one-for-one thing is just simply when the residents need it, that's when they're put in those.
Yeah,
But you
sure.
have to put in a position for one-to-one when we have a lot of nurses' aid, even though they call out, I don't know, what's our rough number on planning? 300
Yeah.
CNAs.
So it's not necessarily bodies, it's just getting them to come to work.
That is a big thing.
Okay,
right.
gotcha.
Anything else before I move on?
Well, I guess, you know, it wasn't that long ago, I forget what the exact, we voted on and made some changes that we're supposed to keep bringing these numbers down.
Right.
You know, when do we actually see that? You know, I think it was probably around 4 or 5 months ago that I think that we voted on changing some of that.
Are you talking about the
Yeah, yep.
Okay. What we're doing is what he was talking about is the recruitment, is we're sending out 9,000 recruitment mailers for RNs to be coming in for the full-time jobs and the per diem. We're looking to build up now that it's getting spring, to build up our per diem pool, which we had just received once we had gotten it through the steelworkers contract. So, yes, you did do that. We are looking to build up the per diem RNs because that will save us money all the way around. We won't be paying the LPNs overtime to do the RNs work, which is what we're ending up doing as supervisors, shift supervisors right now. So that's where a lot of this is coming into play. Okay. Any more questions for Mr. Soto? Because I did want to talk about the housekeeper positions. I wasn't here last night, and I thought it would be good to bring it up. in
Well, we got the
this
second page.
Yeah.
Oh, I'm
we still got-
sorry.
You're way ahead of us, Kathy. You must be eager to go.
Okay. Just to let you know, agency costs, they are approximated at 100,000, but that's not the actual number. Again, we have to wait till the end of the month to report. So the following month for February, we will have the actual number, and it might actually be less than that, just so you're aware. Okay. In terms of compliance and risk, we had 2 visits. One was a revisit on our annual survey, and the other was a complaint visit. The complaint visit was unsubstantiated. There was no issue. The revisit, we did receive a deficiency because it was a situation where a psychiatrist made a mistake and did not put an order, wanted an increase, but didn't put the order in. So we've since spoken to the psychiatrist. We had a plan of correction. The state did accept it, so there was no issue with that. Okay. In terms of our quality measures, everything is actually doing pretty well with regards to that. If anything, we've had decreases in our infection control rate and also in the infection control rate and the facility-acquired infections because we've decreased the number of people who have pneumonia. January is a pretty bad month, so in February kind of recoiled, and people are doing a little bit better with that. Let's see, what else do we have? The satisfaction survey, we did pretty well. We're at 4.03, which is higher than the benchmark of 3. Call-outs are a little bit higher, but about the same. And our turnover rate has actually decreased on all levels. Our percentage of people who are leaving. So that's good. We are retaining the staff that we have. And our star rating continues to be overall 3, regulatory compliance 4, staffing 3, and quality measures 1. What I wanted to talk about real quickly was your attachment there says the Kendall Outreach Program. It is a program that is basically assisting Pennsylvania homes through the Department of Health to reduce restraints, physical restraints, but also chemical restraints. And that means they're trying to help us with the reduction of antipsychotic medication. They have been very successful in other homes like Lehigh Valley County where they've reduced antipsychotic medication by 30%. And what they're doing is they're providing education on a holistic, person-centered approach to involve everyone in the individual who has behaviors and is on antipsychotic medications, even frontline staff such as the CNAs, the housekeepers, dietary workers. Everyone's involved in the process to try to help identify and then help with the process of trying to reduce the antipsychotic medication. And it's been a very successful program. It costs nothing to join it, and we become part of the program to go ahead and help. And if we can reduce our antipsychotic medication, then we can increase our star rating on quality measures, which would increase our overall star rating. So it's a very good program, and we're very excited about it. And that's all I have, unless anybody has anything else.
One more thing here, if we can. Is it possible, instead of just having this dashboard on a calendar year, that it's on like the last 12 months, so we can see, a rolling 12 months? So it's not just, so we only have 2 months now to compare trends or anything to. This way we could have the whole last 12 months.
What I can do is just attach the last 12 months to this, so you can compare the two. Sure, I can do that. I can give you, because I have all of them, so,
Yeah.
What I was trying to do, I know last month was tough. I was trying to give you numbers, so this way you didn't have it, and just trying to compare that way. But I'll just attach last year's with this, and then you could look at both of them and see the trends.
All right, thanks.
Okay? Any other questions?
I have a quick question.
Yeah.
So on our benchmarks for quality measures, I see we're doing okay in some and not so well in others.
Mm-hmm.
But the standard that we have for these benchmarks, are they going to guarantee us that if we meet these benchmarks, our quality measures from CMS are going to go up?
If we consistently meet the benchmarks.
So who set these benchmarks? Are these from the government, or did we we set them?
This is from the CASPER report, which is the report set by the government of what the state average is and the national average is. So it's basically set by them according to all of the data that they collect. So that's what we go by.
So by looking at this, we're looking at, we're basically looking at difficulty with long-term pain and antipsychotic medication use.
Right.
Pressure ulcers are good. Now, we have a benchmark of 0 for the last 3. Well, for 2 of the last 3.
Right.
Is that even attainable?
That's what the state would like us, and actually CMS, state and federal, would like us to have. No facility-acquired infections, there should be no facility-acquired infections, no rate of infection, and no pressure ulcers facility-acquired. That's the benchmark that they set, because they feel that in a nursing home, if they're getting the care and being taken care of, there should be none of that, but no one has been able to reach that. But that's the benchmarks that they put us at, because they feel that no one should have those. So we do our best.
If we're looking at this, some of the most realistic goals that we can achieve are decreases in pain long term, which I'm not exactly sure how you guys are measuring that.
Well, we do have the pain committee that does look at each case individually to see, because pain is subjective. You tell me you're in pain, I believe you. We've had situations where we have residents who are in pain and they're looking for the medication, and then you have to identify that and work with them on that behavior. So it's so subjective, it's really hard to, you have a scale, a pain scale to go by and the assessment to go by, but again, so subjective, so you really have to go with what they're going with.
Okay. And the antipsychotic medication use. So I think these two are definitely achievable.
Right.
And so if in the short run, we come up and formulate a plan, I think we could really be a benefit to our ratings.
Oh, yeah.
Yeah.
Well, we absolutely could, and that's why, I think that Kendall Outreach is really going to help us out a lot, because they're coming in with fresh eyes and a new perspective, and they could really rally us to get together to go ahead and deal with that.
Now, this is definitely an approach to the psychotic medication use, which, I think this is great.
Yeah.
And I'd be interested to see where this goes
next
month.
Well, our QAPI nurse will be following the trends, and she'll be reporting it monthly, and I could share that with you guys.
What is the pain committee's objective?
For the resident to be free of pain.
Meaning, is the pain committee aware of these benchmarks, and are they really kind of going for these benchmarks?
Oh, yeah.
how is their, what is their focus
In terms of the resident or just in general?
in achieving the benchmarks?
Well, like I said, they have to look at every case individually and see what we're doing to deal with the pain.
Yeah.
And they also have to rule out if someone is just a behavior issue that is saying that they're in pain, or if there's actual pain, and what we're doing to try to wean them off the medication,
Okay, okay.
if
Yeah,
possible.
I'd like to see that.
Oh,
I think it's somewhere near it, because we're almost double the measure. So, anybody else have any other questions?
Yeah, just the thing about the opioid and a nursing home is one thing and hospitals are another thing. I'm always concerned that, you know, you could get a really good score on your long-term pain if you just jacked up the medication and you weren't looking at the whole picture of the effect on the individual. I know that's why you PAs and the doctors are so concerned about, you know, fine-tooth that they get the pain addressed, but they don't over-medicate. And that's, I know that out of this whole thing, that's the one thing I'm really concerned about here is the long-term pain. You know, for here, it's not your concern, but also in hospitals. I know that we have the judge here now, and you know,
Listen,
he has.
can I already
he has
introduce that resolution, all right?
He has his, you know, special court for the drug abuse. But anyway, that's something that interests me. That would be easy to bring that number down, but you have to do it in a way that's in the best interest of the patient.
Of the patient, and that they
And also,
don't-
Hayden, with that is, you know, if you over-medicate their pain, then you risk losing on falls.
Yeah.
You know, so
Yeah.
it is a fine balance to strike there. So
It
I'd be
is.
interested to see where you come next month about this.
Yeah, it would be too. That's an area I'm interested in.
All right, well, I'll definitely consult with the pain committee.
Yeah, great.
And maybe we can even get you some information on that and give you an idea of where we're going and what we're doing.
Thank you.
All right. Anything else I can provide you? Okay, have a great night. Thank you.
Thank you.
Okay, moving along. Next item is the update from Allison.
Seth,
Oh.
can I interject something?
Sure.
Last night during the personnel committee, and I actually had questions on this. We were talking about some staff at Graysdale, and I don't know if this is I know it came through the personnel committee. I don't know if this is the time to talk
Not the
about
time.
it here.
It's the time when we bring them up in full council meeting to ask the questions that the people who aren't on the committee to ask that weren't here to ask the questions. That's usually
Well, I think
how it works.
yeah, but we were here and we asked just so, and I don't disagree with you. I'm fine.
Well,
I
it
can
could
do
be
either way.
redundant. I mean, Peg might have the same exact question you have that she's not here. I mean, we could be doing this, you know, or Glenn might have the same question. I don't know. So, I mean, if you know, we
No,
have
that's good.
committee.
I'm fine with that, Ken. That's
Okay.
fine. Yeah.
I mean, it just makes
I
it
see.
simpler and streamlined. It's not part of this, you know, meeting.
Good.
So we defer to the president.
Well, I wasn't asked a question, so I'm just going to move along.
I think, yeah, with that back and forth, you can move right along, and we'll address it during the
Because
council.
you guys are doing your own thing. So. Allison?
Good afternoon, Council. Good afternoon. So, March is Intellectual Disabilities Awareness Month, so I wanted to be sure that everyone understood. The governor did send out a proclamation. In the proclamation, he talks about how individuals with intellectual disabilities are a valued member in our community, and we do support them and their families, and that is something that our Human Service Division does do. Wanted to make you aware that in general, the services for that population are going to be changing. They're going to be more community-focused and less institutionalized, and that is evidenced by the information that the Hamburg facility will be closing. That was a facility that was specializing for intellectual disabilities, that population, and different conditions that they do have. So that's moving forward. But I also want to take this opportunity to thank the Northampton County team that deals with the developmental disabilities program. And that's a very small team. It's called an administrative entity. It has a director, a deputy, program specialist, case manager. So Andy Grossman, Wendy Novak, Mirka Pacone, Lisa Gavin, Susan Gangware, Jennifer Mulchin, I want to thank them officially and formally because they are the heart and soul of that division, and they make sure that individuals with intellectual disabilities get their needs met, and they are tireless about that. So, since March is Intellectual Disabilities Awareness Month, I wanted to be sure to get that in. And now, save the dates. April is when we celebrate volunteers. So save the date, Graysdale Volunteer Recognition is Sunday, April 23, and that will be at 2 o'clock, and this time it will be in Graysdale's main dining room. Used to be in the chapel area, main dining room, that's April 23. Again this year, the Area Agency on Aging Advisory Board will be hosting the Outstanding Senior Volunteer Recognition Awards, and that will be on Thursday, April 27 at 1 o'clock. Same place, Wesley United Methodist Church, and that's on Center Street in Bethlehem. So for the Outstanding Senior Volunteers, they do not have to volunteer in Bethlehem, but they need to be a resident. They don't need to volunteer in Northampton County, but they need to be a resident of Northampton County. So please forward any folks you want recognized, and we'll put that through to the Area Agency on Aging Advisory Board. Jumping back to Graysdale for a split second, I think everyone is aware that the Intergovernmental Transfer, IGT, is occurring again this year. So I just wanted to let you know that it's definitely moving forward. You also heard that we were going for a Veterans Affairs contract. We are moving closer to that in that we had our on-site inspection, and the notes from that on-site inspection have moved from point A to the contracting section of Veterans Affairs. So we are waiting for the contract. I do not have a timeline on that, but I wanted to make you aware we had our site visit, and that was one more step. So, any questions?
Nobody has anything. Oh,
The
okay, sorry.
building. The building. There are no issues with the building. Yes, knock on wood. Knock on wood. Yes, yes, yes. Thank you to Public Works, had it plowed with the snow. Always difficult, with the drifting and the ice, but that was good. Yeah, moving forward.
Great.
Yes.
Yeah, is there any further information you could provide to where we are with the Packer case?
No, actually. I think that everyone's been made aware that when a child dies, there is what is called an Act 33 death review, and it is the State Office of Children, Youth, and Families that is responsible, that's by statute, is responsible for that review. That review is in process, so when you think of an Act 33 death review, think of a multidisciplinary, multi-pronged approach to looking at a situation and determining who, what, when, where, and why. Not just why, but how. And is there something that was missed? Is there something that we could do different in the future? All of those questions are part of that review, and that is occurring. And Northampton County is a part of that, as well as all other parties in that situation. So that's what's happening there. We are making sure that all of our children in resource families are getting the best care that they can. Resource families are individual. They do the work of angels, really, and we want to be sure that we take a look at each resource family individually and each foster child individually. Each foster child has a guardian ad litem, which will also assist with reviewing to be sure that everything is copacetic. And as you know, when there is an adjudication of dependency through the courts, that also means that the courts are involved, and the timelines and the monitoring of the Children and Youth Agency with the court system, that's well established, and that continues as well. So we are addressing directly the children that were specifically in the Impact Foster Care Program. But if a placement is working fine, we're not going to change it just for political expediency. foster care parents, resource families do the work of angels, and they are independent, and they need to be reviewed and monitored independently as well.
Thank you.
Surely.
Yeah, I did. I got your email, and I saw that we had severed ties with the Impact Project. So there's nothing else that, this council needs to be aware of at this time?
Correct,
or-
nothing else. We're
No?
still in the middle of going through everything thoroughly and making sure that we do right. And of course, working with the state as they conduct their investigation as well.
Okay, fair enough. Hi, does anybody else have anything else? No? No, okay. Okay, thank you, Alice.
Thank you.
Okay, that was the last item on our agenda. If anything, nobody has anything else, motion for adjournment? Second? Okay, good. Thanks.